My screen visible?
Yes.
Okay, thank you. Thank you, Arun, for quoting me, but you have not quoted many other things which I will be quoting, which I have been talking about. Sorry. I'll just full screen it. So my worry is not about pharmacological projection, but the aggressive pharmacological projection that is going on to prevent myopic progression in children. And I don't have any financial interests. And unfortunately, there is a lot of financial interest in this massive projection of atropine, and I'll discuss. What do we know about this? And as Arun brought out, that it's like the corona pandemic. Childhood myopia is like the corona pandemic. We do not know much about the disease. There is huge fear mongering. We are clutching at straws for treatment, and we do not know how this treatment we are touting actually works. We'll take each point separately. While parental worry for myopia is there for more than 100 years, increasing near work has been blamed. Our mechanism or our understanding why it's happening is unclear. We've talked about lack of play, academic high achievers have it, tabs, phones, computers are at fault, although they are a very recent addition to our children. Television, vitamin D deficiency, nowhere, no one has ever shown atropine deficiency as a cause. Huge fear mongering. This article is oft quoted, just quoted by Dr. Arun. The big thing, although I respect this article and it's a wonderful one projecting 50% myopia by 2050, this report actually missed 1/6 of the world's population, that is India. Our prevalence at the moment is around 10%. Three of our papers have actually shown this. It's important, need to worry, but not crippling, not that fear mongering we are talking that make us ignore facts about the treatment we're talking about. We're clutching at straws. This is not a revolutionary or a miracle discovery done for treatment of myopia. Atropine for myopia dates back to the 1960s. Doses have been tested from 1% to 0.01%. Despite having more than 20 years of experience in low dose atropine, it's still not FDA approved, believe it or not. It's not marketed anywhere in the world, including East Asia, where 70 to 80% children have myopia. It's not even licensed for sale in Singapore, where these ATOM studies were done. It's only for SNEC enrolled patients, except in India, of course. It's an over-the-counter drug. You can take bath in it. And of course, probably we'll soon have atropine eyeliners and mascaras as a treatment option. Talked about ATOM 1, Dr. Arun did. 1% versus placebo showed that it's effective, but too many side effects. It acts probably by accommodation arrest. ATOM 2 tried to reduce that by 0.5 and 0.1. And 0.01 was the placebo. It was 100th the concentration of 1% that was effective and considered a placebo. They found that it's effective, but atropine is dose dependent and so are its side effects. So 0.01% is acceptable, not scientific evidence. In fact, right on cue, we now have a low dose concentration available, which is 0.05%, which is showing it's more effective than 0.01 and has equal side effects or very less. And there is this huge puzzling disconnect. 0.01% atropine slows refractive changes, but does not slow abnormal eye enlargement. Any myopia control must slow the rate of eye elongation because that is the cause of side effects in pathology's later life. At present, this just reduces the power of glasses, no long-term safety. In fact, this recent viewpoint has very aptly put that despite evidence that it is not showing eye elongation reduction, it is being rapidly adapted in clinical practice and widely used, which is both unfortunate and concerning. It is completely harmless, as Dr. Arun said. We just don't know how it works. It acts through some receptors, but then what are those receptors for which we are blocking? There are no side effects today. But remember, we need to put these drugs at least for 2 years in growing, developing eyes. 2 years daily
60 seconds left.
12-year-old children. 1 year just to see efficacy, plus the rebound effect. So rapid myopia occurs the moment you stop, atropine drops. Is this the best available treatment? My biggest objection is that it diverts attention from alternate and proven effective treatment. Outdoor activity, multiple studies have shown more than 2 hours of outdoor activity definitely and significantly reduces progression. Soft multifocal contact lenses are now FDA approved for control of myopia. Orthokeratology, other drugs like perinzepine, 7-methylxanthine, timolol, all have shown effect. These are the alternatives. And this graph of atropine that you're seeing is all the doses that you have, and you have a lot of alternatives. And so I leave you with this photograph of keep myopia away, go outdoors and play is the slogan from Singapore, where atropine came out. And it's not go use atropine. Please show your aggressive behavior in educating the patient, giving all the options, encouraging outdoor activity, which is actually free treatment and good for the general health. And don't bind the child ears with treatment that is yet to prove itself. Thank you very much.